Hey, it's Beth Wright providing you a podcast for Unit 5 NUR 236, and we're talking about the heart perfusion. Perfusion 1. Okay, so it's all about the beat, Yeah, I love that song, but I changed the words a little bit to it. So it's all about the electrical part of the heart. And of course, dysrhythmias are any abnormalities in the cardiac rate or rhythm. And of course, we pick up on this by feeling the pulse. You can feel arrhythmias or dysrhythmias when you're checking a pulse in the radial area or apical area, or listening to the heart and the apical pulse, and listening, on our different areas of the heart as well. So we got to think again about the heart as that electrical pump. We talked about it with the heart failure as being a pump, but now we're going to talk about it being the electrical pump. And the electricity resides in those specialized cells that generates and conducts electrical impulse. And it's just fascinating to think about this. And this is called contractile tissue. Then, of course, activities result in effective cardiac contraction and blood distribution throughout the body. So that's how we maintain and live through all of this electrical activity. We got to have it, or we won't have that blood flow going through the heart, to the heart, through the heart, and from the heart. So when we think about a heartbeat, it actually has 4 different events. First, we have that stimulation from that electrical impulse, so it's firing. And then we have the transmission of that impulse, the electrical impulse, to the tissue around that area. Then we have the contraction of the atria, then the ventricles. And then we have relaxation of the atrial and then the ventricles. So the word cardiac automaticity is talking about the heart's ability to generate an electrical impulse. Sometimes we have too much automaticity going on, but any part of the electrical system of the heart can start an impulse. So we have the SA node that has the fastest rate, and that's our pacemaker site. And that's dependent, the automaticity is dependent on the sodium and calcium ions in the cells and potassium of the cells to make the charges and the contractions occur. So, we have, you learned that back in chemistry, you've learned that in anatomy and physiology, but definitely the sodium, the calcium, and the potassium all play a big part in that conduction and contraction and electrical impulse of the heart. And hence, when we get into talking about the medicines to treat dysrhythmias, you're going to hear those names again. Because you're going to have this anti-dysrhythmic medicines that block the sodium, you're going to have some that block the calcium, and you're going to have some that block the potassium as well. Now, depolarization happens when electrical energy discharges and the muscle contraction occurs. And I like to think about that as, that's your electrical impulse, and then we have repolarization where it's resting. Then we have our cardiac excitability, and that's the heart's ability to respond to electrical stimulus. So we have the automaticity, that is the heart's ability to generate that electrical pulse, and now we have the cardiac excitability. How do we respond to that electrical stimulus? So after contraction, there's a period of decreased excitability where the cells cannot respond to new stimulus. It's like, hey, I got to get a rest. I got to take a break here. and that's referred to as the absolute refractory period. The heart's conductivity is the heart's ability to transmit that electrical impulse. So I like to think of that as the heart being the conductor. And when you think about the conductor, you might think about, the conductor on a train, or, in physics and in electrical engineering. A conductor is an object or a type of material that allows that flow of electricity current in one or more direction. And it's just amazing how the heart is able to be a conductor of that electrical impulse. So the normal electrical impulse is the SA node, then it goes to the AV node, then the bundle of His, then the bundle branches, and the Purkinje fibers, and then throughout the whole ventricular muscle. Impulses are delayed for a period of time there, and then they also travel in a predictable route, typically. So this is just a picture showing that whole conductivity of the heart. And again, to me, it's just fascinating to think about. We're electric. Now, cardiac dysrhythmias can come from anywhere. Anywhere there's disturbance of that automaticity, the heart's ability to start an impulse. It can originate from disturbances of the conduction system, the SA and AV, pathway that we talked about, or it can be from atrial or ventricular muscles having an issue. When the electrical impulse comes from somewhere else other than the SA node, the focus is abnormal, or they refer to it sometimes as ectopic. So, you know this already. Tachydysrhythmias are when the heart rate's greater than 100 beats per minute. Bradydysrhythmias are those that are when the heart rate is less than 60 beats per minute. And, lots of different things can cause those. Shortness of breath, hypotension, anxiety, all of those can cause dysrhythmias. Electrolyte imbalances, acid-base imbalances. So these things definitely need to be assessed when we're, treating somebody for dysrhythmias, because certainly don't want to start them on any medication if it's something that can be corrected, like an electrolyte imbalance. And you know that already. You know how potassium, magnesium, those electrolytes can definitely cause changes in the heart rhythm or dysrhythmias. So it's very important that we make sure, it's not something that's easily corrected, or make sure that if it is something, that we're checking all that kind of thing out. I mean, goodness sakes, too much caffeine, as you all know, can cause you to have a tachydysrhythmia, stress, test taking, that kind of thing. So we know that there's lots of different things that can cause dysrhythmias. Ectopic beats can come from hypoxia, ischemia, hypokalemia, hyperkalemia. It indicates that there's some kind of irritability with the myocardium. And so, we got to be sure, try to determine the cause, and then also, keep it from happening again. Because, when the heart's not functioning right, then the whole body's not functioning right. And so we gotta act on that. So this is just a normal rhythm there, and you see your P wave. Anytime we're talking about that P wave, we're talking about the atrium. The P wave is all about the atrium. And you can see the atrial depolarization, meaning the beat. You got your electrical pulse there. So it's the atrium there, where it's contracting. Then you've got your QRS, which is your ventricular depolarization, and it also is your atrial repolarization, meaning it's resting. So you got your atrium that's firing, then your atrium rest and your ventricular fires, and then you have your ventricular repolarization at the T wave there. And again, it's just think about repolarization as your resting period there. And so here are some rhythms for you. You can look at the top, the A fib there. Again, atrial fib, that's where your P wave. You don't see really a P wave in there anywhere. So that's a classic sign of your A fib, is the lack of or discernible P wave. You can see atrial flutter, that looks like sawtooth. That's a way, kind of a known way to remember that is the sawtooth rhythms there before your QRS. And then you have your SVT. So your SVT is supra meaning above, ventricular, so above the ventricle, tachycardia. Okay, it's very fast rate. You can see it's really, really fast, and it's hard to distinguish between the T wave and the P wave on that. In your top one there, the premature ventricular contractions, PVCs, you can see the abnormal beats. They're kind of in the center and then closer to the right side. Those obviously, you know, we're moving along pretty regular there, and then all of a sudden we have this abnormal beats going on. Okay, so that's your premature ventricular premature ventricular contractions. Look at your next one there, the VTAC. The VTAC, there's no P or T wave. Now, at the end there, you know, again, we're kind of moving along regular, and then you see that PVC on the VTAC one, and then you kind of it's kind of regular. I don't know, there's some definitely irregular beats there, and then all of a sudden we go into wham, very fast beats there, right? And, you know, of course, be sure to check your patient when something like this happens. Numerous times you rush into the room because the telemetry unit has called and said, your patient's in VTAC, and you run in there and your patient's scratching their chest really hard. So, you know, so things like that can happen. You've got to always check. Remember, you've got a machine here that's checking this and getting these rhythms down, and anything can be going on with the machine. Always, always, always check your patient. And then VFib. So you see this chaotic, crazy rhythm there for VFib, ventricular fib. So the antidysrhythmic drugs, the newest goal of therapy is to prevent, relieve symptoms, or prolong survival. And the primary goal or prior goal used to be to suppress it, but you know, that's sometimes resulted in a higher mortality rate. So we want to prevent it if we can and relieve symptoms and prolong survival. Indications for use can be a conversion of atrial fib or flutter to normal sinus rhythm. It can be to maintain the normal sinus rhythm after a post-conversion of the atrial fib and flutter. It can be to suppress or a fast or irregular ventricular rate, or any presence of dangerous dysrhythmias that are potentially fatal, okay, to treat them. So the mechanism of action is that it deals with those words that we talked about earlier. So it reduces automaticity, meaning that remember that automaticity is the heart's ability to generate the electrical impulse. It can slow the conduction of the impulse through the heart. So again, the heart's ability to transmit electrical impulses is what conduction is. So it'll slow that down. And then it can prolong the refractory period. And that's the period immediately following the passage of the nerve impulse or the contraction of a muscle fiber. Now, the medications are classified according to the mechanism of action and the conduction system effect. Non-pharmacological therapy is going to be, a preferred initial treatment for several dysrhythmias. Antidysrhythmias can make things worse. It can cause additional dysrhythmias, and it can have a high mortality rate. So if we can treat it without antidysrhythmias, that's wonderful. Such as, and here again, it's why we want to know what is the cause. If it's an electrolyte imbalance, we can definitely get that taken care of. If it is too much caffeine, we can take care of that. So that's why it's important to try to figure out what the cause is. Okay, so pharmacological therapy definitely requires an accurate identification of the dysrhythmia because certain meds are used for certain dysrhythmias. Understanding the mechanism of the dysrhythmia and observing the hemodynamic effects and the ECG effects of the dysrhythmia. So, like when you give a dysrhythmia, you need to be checking the patient, getting you baseline ECG, vital signs, and then during administration, many times, you're going to be checking all of these things again, vital signs and a continuous ECG. And then after the medicine is given, checking all that stuff again. Knowledge of the pharmacological actions of specific medications, obviously, you know that. And then the therapeutic effects will outweigh the potential adverse effects, we hope. Okay, so here are our class of medicines, or your exemplars, the quinidine and lidocaine. Those are class 1Bs. And your beta adrenergic blockers, or beta blockers. Your amiodarone is a potassium channel blocker. Your diltiazem is a calcium channel blocker. And then adenosine and magnesium sulfate is unspecified. The quinidine and the lidocaine are actually sodium channel blockers, class 1Bs. Alright, so let's get into talking about them a little bit. So quinidine is an old drug that's been around for a long, long time. They don't use it anymore, hardly ever, but we still have it listed there. It blocks the cardiac sodium channels and slows conduction, and how fast that electrical signal can travel in the muscle. Okay. The use is for atrial dysrhythmias, SVT, and chronic ventricular attack without heart block. It is made from cinona bark, and it depresses the cardiac function. Toxic effects include several things. Synchronism. Patients will have tinnitus, ringing in the ears, nausea, impaired vision, and vertigo. May also see a hypersensitivity with skin rash or worse, respiratory arrest, and vascular collapse. So these are pretty serious adverse effects. It's administered orally with meals to help with the decrease in the GI upset. Also, if the patient is hypokalemic, this will decrease the effectiveness of the med. If they're hyperkalemic, it can increase the effects of the med. So obviously, the potassium would need to be monitored here. Nursing care with this, we're going to monitor the skin for you can see the list of contraindications there. Second and third degree block, myasthenia gravis, pregnancy, lactating, and thrombocytopenia. And the special population with this. It does have to be reduced dosage in renal and liver impaired. The adverse effects, central nervous system, can be vision, photophobia, blurred vision, not even double vision. And of course it has the nausea, vomiting, diarrhea for the GI adverse effects and the liver. And of course dysrhythmias. So the nursing care, we're going to assess the skin, the level of consciousness, and the central nervous system. We want to assess the grips and reflexes, you know, that kind of thing, especially if we're thinking myasthenia gravis. And watch for edema and monitor vital signs, renal and liver function, breath sounds, and teaching for the patient. Okay, lidocaine is another sodium channel blocker, and it has a rapid onset. It's given IV push, and it can also be given sub-Q. We're going to talk about that in a minute. So again, anytime we give medications that affect the heart rate like this, we're going to continuously monitor that ECG. That's essential. The lidocaine shortens repolarization and decreases irritability in the ventricle. So I want you to think about lidocaine, you know, Novocaine. All of those are anesthetics, right? And so it numbs things, right? Like when you go to the dentist, they use the Novocaine. Okay, same difference here. This is what this is. It's anesthetic, basically. But it's been found to help with dysrhythmias. Now, high doses of lidocaine can cause drowsiness, mental status changes, and paresthesia. And toxic effects can cause seizures and respiratory arrest. Got to watch about therapeutic serum levels for this medication if it's given more than just one time. Of course, you know what you'll want to have close by with this medicine. A crash cart would be ideal. The other thing about this is it can cause malignant hyperthermia. And just remember about that from your perioperative nursing way back when. Lidocaine's metabolized in the liver, so patients with liver function problems are going to need smaller doses. And again, remember that it is used as a local anesthetic, so be careful to read the label of the drugs carefully if you're ever giving them. It should not be given for bradydysrhythmias. It can cause excessive depression of cardiac conduction, so it would only worsen a bradydysrhythmia. So this is a QSIN alert about the lidocaine issue with not reading the labels well. If you look on the left hand side, that is the medication that is given and what is located in crash carts. Okay, that's what's given to patients who have cardiac dysrhythmias. Look at the one on the right side. That one has epinephrine. And you don't want to give epinephrine to anybody who's having cardiac issues, right? Because epinephrine can cause additional cardiac issues. And so you see lidocaine and epinephrine used like sub-Q when they're suturing somebody up that's had a severe laceration or something. And they'll give that sub-Q to numb the area, and the epinephrine will help because it will vasoconstrict. It will help with stopping the bleeding to the area, and so that's the only time that medicine would be used. So always pay attention to what you're giving, and take a look at that label really carefully. Okay, the next group of medicines is the beta adrenergic blockers, and you're going to see these over and over again. You probably already have, and you can recognize this class by that end of their name, the generic name, OLOL at the end. And these drugs have pretty much eliminated the use of quinidine. So these drugs block the effects of the sympathetic nervous system stimulation. And by blocking that stimulation, the heart rate is reduced, the contractility of the heart is reduced, and think about, oxygen consumption is decreased as well, and the blood pressure is decreased, as well as the decreased rate of conduction through the AV node. And we'll see these drugs again when we talk about the antihypertensive drugs. So again, with all of that being affected, you know what you're going to have to monitor. The heart rate, the blood pressure, and cardiac output. Now, an indirect measure of cardiac output is urine output. So if the urine output is decreased, then most likely your cardiac output is decreased as well. It's usually given orally, but in emergency situations, you can give this IV. Most beta blockers block both beta 1 and beta 2s. Okay, so beta 1, remember, it's a heart that deals with the heart directly. You only have one heart, so beta 1 deals with the heart. Beta 2s deal with the lungs. The lung receptors cause bronchodilation, so if it blocks the beta 2s, then that would cause bronchoconstriction. So, beta blockers that have an effect on beta 2 receptors are contraindicated with anybody with chronic pulmonary disease. If someone overdoses on beta blockers, the effect may be treated with epinephrine or norepinephrine. And it's contraindicated with AV block and sinus bradycardia. Now let's talk about our potassium channel blockers. Amiodarone blocks the potassium channels, okay? And it may be administered orally or intravenous for a short period of time due to the adverse effects. Has a vasodilating effect. It decreases systemic vascular resistance and prolongs conduction, decreases the heart rate, and decreases contractility of the left ventricle. And it's used for tachydysrhythmias, ventricular and atrial dysrhythmias. Now, it's got some really serious side effects and adverse effects, and a black box warning as well. So they usually try to not do amiodarone unless it's just absolutely necessary, because it can cause pulmonary fibrosis. And that's signs of that would be persistent non-productive cough, dyspnea, and chest pain with deep inhalation. It can also cause yellow-brown granule deposits in the cornea. It can cause photosensitivity, hepatic dysfunction, muscle weakness, bradycardia, and also, even stranger, a bluish discoloration of the skin. Contraindicated with allergies and bradydysrhythmias, AV heart blocks, cardiogenic shock, hypokalemia, and think about that, because it's a potassium channel blocker. You can't, it's got to have potassium to block potassium, right? We've got to have potassium in our body to block it. Lactation and sensitivity to iodine is also contraindicated. We've got to be careful with pregnancy and thyroid function. Administration, we got to watch the heart rate, keep it between 60 and 100. We got to teach the patient about eye exams and pulmonary checkups constantly for, checking about that adverse effect. Calcium channel blockers, diltiazem is one of those. So again, here we're coming back. I told you those, you would hear those again. The prototype there is the diltiazem, and it's used for SVT, AFib, and AFlutter. And other populations, pediatric, there's no safe evidence there for them. Now the way this works, it blocks the entry of calcium into the cell, and for myocardial cells, that causes a slowing of the heart electrical impulse and contractility of the heart. So this can also be used to help treat angina as well. For vascular smooth muscle cells, it causes relaxation and therefore dilation of the blood vessels and helps lower the blood pressure. So it works by obstructing the movement of the calcium into conductive and contractile myocardial cells by inhibiting the influx of calcium through its channels, causing a slower conduction through the SA and AV node. So monitoring when patients are receiving calcium channel blockers, we know is going to be, as it is with all of these, heart rate, blood pressure, cardiac output. Note that this class of drugs and beta blockers have the same effect, but they just work differently. So we've got to be careful about patients who are receiving both of these drugs from both of these classes. And you'll see that quite frequently. Usually these meds can be given orally, but they can be given IV in an emergency situation, and they are titrated. So meaning that the nurse will titrate based on the dysrhythmias. So you may see that kind of situation either, in practice or as a test question. Adverse effects, CNS, dizziness, lightheaded, headache, asthenia is abnormal physical weakness or lack of energy. Cardiovascular, of course, peripheral edema, bradycardia, AV block, flushing, and nausea. Wanted to mention the contraindications is renal and liver impaired. Sick sinus syndrome, that's also known as a sinus node disease. It's basically where that sinus node is sick. And you can either, you can either have a heart rate rhythm that's too fast or too slow, punctuated by lung pauses, or a combination of those with sick sinus syndrome. It's a rare thing in younger people, but you might see this in your older population. So nursing here, we're going to check about drug-drug interactions. That's going to be important. Avoiding grapefruit for just about all of these. I haven't mentioned that thus far, I don't think, but grapefruit, it doesn't mix well with these meds. We're going to check the blood pressure, pulse, and the ECG, obviously. And there's extended long-acting medicines, and we're going to monitor for those therapeutic and adverse effects for sure, and provide that teaching. And be sure to read about the teaching in your textbook. Adenosine is under the unclassified, and this is indicated only for paroxysmal supraventricular tachycardia. And paroxysmal is a sudden onset. So supra is above, ventricular tachycardia. So it's, in other words, a sudden onset fast heart rate greater than 150 beats or more that originates from above the ventricles. It works by slowing the conduction of the heart's electrical impulses. Patients who take any xanthines, medications for breathing like theophylline, might need larger doses of this particular medicine. So this is the coolest medicine in some ways. The half-life of adenosine is only seconds. So it's got to be given really fast. And when you draw up the medication, you got to also draw up a 10 to 20 milliliter of normal saline to flush. So you push, you do an IV push. You push the adenosine very fast in the port closest to the IV site, and then you follow quickly with the flush, and you flush it fast. Because the half-life is so short, any side effect that the patient has will go away in just a second or just a minute. To be effective, adenosine stops the heart for a few seconds and then restarts it at a slower rate. That's the desired effect. Okay? Yo, yo, yo. That's a little scary, isn't it? So what do we need to have nearby? In case something goes wrong, in case that doesn't, the desired effect doesn't happen, we better have a crash cart nearby, right? Okay. Magnesium sulfate is the treatment for torsades, and that's a management of a severe tachydysrhythmia. Hypomagnesium increases myocardial irritability, causing atrial and ventricular dysrhythmias. So we need to be sure to check the mag level of patients and provide replacement therapy as needed. Okay, so in your notes you have different things about children. There's from time to time the medicines can be used for children, and then there's times when it can't be. For older adults, it's always going to be an issue because of decreasing function of all the organs. Renal impaired, most always going to be a concern, and possible dose reduction. Liver impaired as well is going to be a concern. Amiodarone is hepatotoxic, so we got to assess the liver function. Diltiazem is contraindicated in renal and liver impaired. For critical care patients, you're going to have patients, a lot of these meds are going to be used there, and you're going to have multiple IV lines and pumps everywhere on some cases, and like 8 and 9 lines, IV lines, and so keeping all that organized and monitoring the ECG and the vital signs, all that's going to have to be done, and a lot of care is going to be provided there. And of course, with home care, we're going to, do the vital signs and heart rate, blood pressure, heart rate, check about the urine output, and monitor, for adverse effects and therapeutic effects. Okay, this concludes your podcast.